Today is Monday, July 12th, 11:45 a.m. Pre-surgery testing and meetings with the doctor prior to the reversal surgery. Just waiting on Dr. Fazio to come in right now and go through whatever questions I may have and instructions that he may want to give me.
Mr. Wilson?
Yes.
Hi, I'm Dr. Harriet. I work with Dr. Fazio.
Dr. Harriet.
Nice to meet you.
Nice to meet you.
Now, we're planning to close your stoma on Thursday.
Right. One question for real quick. I spoke with Marlene and the nurse who was here before, asking if I could videotape.
Doesn't bother me.
Okay.
I want to do that.
Dr. Fazio won't be coming in today then?
He will. He'll come and say hi to you.
Okay.
Alright, I mean, I'll run over the stuff with you as
Okay,
well.
great.
Just check your frips.
Just wanted to make sure you knew I had that on, so I didn't.
No, I realise.
Sorry.
So we're doing this on the 15th.
Yes.
Okay. Get you up on the computer. The gastrographin looks fine. So everything's all healed up, which is good.
Right. We did that, I think, in May. As far as it goes with everything healing, we'll be closing the stoma on the 15th, this Thursday actually.
Yeah, that's the plan.
But as far as what kind of physical exertion can I do after this surgery? Do I still need to watch as far as lifting weight and?
Yeah, I would still. We close the stoma by mobilising it
Okay.
around the stoma. 99% of the time we can do it locally. Very occasionally you have to do a midline laparotomy to make a hole in the middle,
Okay.
but not often. We mobilise the bowel, free it up fully, pull it out, freshen the edges and close it.
Okay.
Push it back in, close, put some stitches in the abdominal wall, so we close the muscle and the fascia,
Right.
but we leave the skin open.
Okay.
Alright, reduces the risk of infections. You'll find after 48 to 72 hours the size of the wound will shrink right down.
Okay.
Be about the size of, say, a dime.
Right.
Well, start the size of a quarter will shrink down, then it'll just fill up with tissue.
Okay.
Alright. The risks, you've been in hospital about 2 or 3 days. Like any operation, there's anaesthetic risks,
Right.
risk of chest infections,
Right.
crossing your legs, wound infections. And the surgical risks, there's always a risk of bleeding, but that's small. There's always a risk of a leak, because we're closing bowel.
Right.
Again, the risk of that is probably less than 1%, but it's present.
Right.
Right, and if you did leak, you might need to have the stoma put back.
Mm-hmm.
If that happens, it's normally after about 7 to 10 days. But
Okay.
so you'd be at home.
Okay.
So if you develop severe abdominal pain, you need to contact us.
Right.
But it's very rare. The other risk is sometimes where we've done the closure, you get some swelling at that site, such that your bowel takes a bit of time to get working.
Okay.
Again, that's not common, but can happen.
Right.
Alright.
This procedure itself takes how long, as far as closure of the stoma?
45 minutes to an hour.
So no more than an hour. Okay.
Yeah, I mean, it's not a long procedure.
In 2 to 3 days in the hospital, just to make sure everything is flowing through and
Yeah, we
accepting of the.
we basically make sure you are tolerating diet.
Okay.
We don't have to actually wait for you to have your bowels open.
Okay.
I wouldn't specifically wait for that. Okay.
Will you be part of that surgery, Dr. Harriet?
Dr. Fazio will run 2 rooms. Depends if I'm in that room or in the other room.
Okay.
So, and that will depend on what the cases are.
So he'll be doing the procedure himself, though?
Either I'll do it supervised by him, or he'll do it.
Okay.
Or another surgeon will do it supervised by him.
Right.
Basically, and it may be that we'd start the mobilisation. He's always there,
Right.
basically, and we'll supervise everything. If he's not happy, he'd
Okay.
change it. grand. But yes, basically everything is supervised and done by him, either by him directly or under his supervision.
How long have you been in your fellowship here?
I've been here since December.
Okay.
I'm a board certified colorectal surgeon in the UK, so I finished my training in the UK. So I'm a fully trained colorectal surgeon.
Right.
But I'm doing this as an extra year of training.
Okay.
Really just to get some American experience, get the chance to work with Dr. Fazio for a time, and work with the other staff. Which is, it's excellent training.
I'm sure it is for you.
Okay. You had your gastric enema in May, didn't you? You were saying?
And I believe he looked at the pouch last time I was here in May. Just can't recall. Would that be documented there in the computer?
I'll have a look.
Okay. That's one out.
What's supposed to be normal? Okay, yeah, we did. Manometry normal.
So he did, okay, that's okay, I can't remember. We've run so many different tests and things, I can't recall it all. So we probably don't need to look at it today then, right?
No. Okay, you've got polycystic kidneys.
Yes.
Haven't had any steroids since April.
Correct.
Okay, don't even have a listen to your heart and chest. Set yourself up here.
Okay. How long does the J pouch surgery usually last for?
Completely buried. I'll average about 3 hours.
I mean, as far as after the, is it something that will function permanently for the rest of my life, or is it a?
On the follow-up we have, the first patch was done in about 1978. So even then you're looking at the longest follow-up, so about 26 years.
So it's still functioning, okay.
It's still functioning. You've got people who are still functioning. They're
Right.
probably what they've done the most patch in the world here, and they can give you the best deep information on that.
Yeah. It depends on how you treat your body yourself afterwards.
Things are still, information is still developing. It's
Right.
still a relatively recent procedure. It only has a history of 25 years.
Right.
But people seem to have good function in the long term.
Okay.
Just lift the t-shirt up for me, sir. Hold your breath. Breathe away. Deep breath. And down. Yeah, that's fine. Just raise yourself back, sir. Just want to lay a hand on your tummy. Cough for me. Okay.
This spot right here, I don't know if you noticed, but it's kind of hard to tell with this bag in place, but it's kind of swollen here still.
Yeah.
Surgery, it's numb.
That won't change when we close your stoma.
It won't change?
No, that's just the nature of. That's the nature of the fat, really, having closed your tummy. Right, it may be slightly different when we close the stoma.
This side here is fine. I have
Yeah.
feeling it's flat, but over here, it seems to have just, the abdomen is
Generally,
pushed out a little bit.
it is. That's just the tissue. You'll find it may appear slightly different once the stoma is closed.
Does that tend to go down at all, or it's hard to
It
say?
may go down, but I can't say it's going to be. It'll go back to what it was before you had your surgery.
Is there anything that can be done about that, or?
we wouldn't generally do any sort of sensation-wise. It'll improve.
They will.
Right, that will improve in time. The actual appearance we probably wouldn't do anything about. I wouldn't suggest doing anything sort of plastic surgical for that.
You wouldn't suggest plastic surgeon doing anything?
Well, really, because we're not. You're looking at sort of cosmetic change. They probably couldn't make it any better.
Right.
The scars weren't healed.
Is that a case-by-case basis, or is that something that happens typically with this type of surgery?
It varies. People's, after any sort of laparotomy, midline incision, the appearance of people's abdomens will vary.
That's the side that the drain was on. I wonder if it's something from the drain, maybe that everything didn't drain out, or...
I doubt it.
Okay.
It just looks like normal tissue.
Diet-wise, I've been very cautious, obviously, with seeds and nuts, raw fruits and vegetables for the skins to avoid any blockages. What about after this surgery?
Still avoid all of those for the first month.
For the first month, avoid them.
Because it will be a bit swollen where we actually close the stoma.
Okay.
So nothing to eat or drink after midnight.
Okay.
Right.
Prior to the surgery, right?
Prior to surgery. I'll just take clear fluids after lunch today. Alright.
After lunch, just clear fluids. So nothing else as far as bowel prep, no drinks or anything like that?
No, you don't need that. But we'll see if he wants to have a look in the pouch tomorrow. If so, we may give you an enema tomorrow, just to clear the pouch out. So I'll probably give you an enema when you come in into pre-op.
Okay. The day of the surgery?
Yeah.
So just clear fluids after lunch the day before, okay.
You had some blood taken today?
Yes.
You haven't got your renal function back yet.
Did EKG as well.
Okay. Anything else you want to ask about the operations?
Expectations as far as number of bowel movements after the surgery? Right now I have to do a
On the
pouch.
studies, on average, it's around 6 to 7 a day.
Okay.
It varies between different people. You'll find people's function. It'll take a few months to settle down anyway. We may need to put you on something like Imodium just to slow the valves down a bit, to thicken things up.
Right.
Stool will be generally putty-like, never be normal, sort of more solid stool.
Right.
And your function can improve over 1 to 2 years. Actually, function does change over that period of
It
time.
improves it overall?
Yeah, the pouch starts to actually may increase in size slightly.
Okay. Because it seems like right now I'm emptying that pouch up to maybe 10 times a day in a 24-hour period.
Yeah.
So I don't know if the bowel movements would be that on a similar
It'll,
schedule or
to
be
begin
less?
with, you may find you're opening it quite frequently.
Uh-huh.
Right.
Recovery-wise at home, then people typically are off of work how long before they can function in a daily routine, sort of a
3 weeks or so.
so
3 or 4
about
weeks.
a month. Going back to the physical exertion as far as lifting any weight or twisting and turning, like for example golf.
I wouldn't start playing golf for over a month.
So okay, so at least a month minimum. I was worried about the twisting and turning of everything internally.
Internally, it won't do you any harm.
Yeah.
But just from the abdominal wound, I'd wait a month.
Sort of sit-ups, exercising,
Again, I'd wait a month.
a month minimum.
Just take things gently.
Okay.
If you do something too active and it hurts,
Right.
don't do it.
What about supplements, vitamins, things of that nature? Any recommendations?
If you're eating a healthy diet, it shouldn't make any difference. You're not going to do yourself any harm. If that's what you take normally, that's fine.
Is there any sort of deficiency that is typical with this sort of surgery because the large intestine is not there to absorb
You can get vitamin B12 deficiency. is what
vitamin
can
B12
happen
sometimes?
sometimes because you've lost your terminal iron.
But that's not anything out of the gate that we have to worry about.
No.
What would be a symptom of if I am B12 deficient?
You get anemic. You can get tired.
Tired. And then how about follow-up appointments after this surgery?
We normally see people yearly. But for a patch follow-up, we'd probably see you once by, say, 3 months.
So maybe 3 months after, then once a year.
Every yearly
Every
after
year.
that.
I think that runs through all the questions, 1 hour. Yep. That was all I had.
So, probably just stay on clear fluids today, actually. Easiest thing. Rather than have lunch, just have clear fluids today.
Today?
Yeah, clear fluids today. Don't eat any bowel prep.
The surgery's not till Thursday.
Oh, it's Thursday, sorry,
Yeah.
forgive me.
Okay.
The day before, clear
Okay.
fluids.
So a couple of days I have to eat for the next 2 days.
No,
Was-
you can eat now. Clear fluid, have breakfast, then clear fluids the
After,
day
okay.
before. Nothing to eat from midnight. You have an enema when you come in, just so you can clear out the pouch so we can have a look.
Right.
Check the pouch looks fine. That's everything we need to do.
Okay.
Then we get, if you've got no other questions, we'll get Dr. Fazio to pop in and say hello to you. That's
Okay,
all
great.
I need to do.
Very good. Thank you much.
That's it. Nice to meet you. I will see you on Thursday.
Okay. Good luck
Dr.
during the
Fazio.
fellowship too.
Ah, it's fun. Now it's just looking for a job.
Yes. Take care.
Alright, nice to meet you.
Yes.
Hello.
How are you?
Good. How are you?
Very good.
Are you Mr. RITSON?
Yes, I am.
Did I pronounce that
You
correctly? Dr. Harriet was just in, and he said it'd be okay and come to talk to you. My name's Ann Dugan. I'm a
Okay.
research nurse with the department,
Okay.
and we
I'm
haven't.
gonna do one thing, Ann, before I keep going, because I've
Okay.
asked if Dr. Fazio if it's okay if I videotape our meeting today when he's here,
Okay.
but I'm not sure what you and I are gonna go over. If I should turn that off.
Well,
or-
that's up to you. We have a department study going on, people having stoma closure surgery. We're trying to track like length of stay, look at discharge criteria, look at bowel function
Yes.
returns. So I wanted to talk to you and see if you might be interested
Okay,
in
sure.
participating. If you wanna keep your video running, that's
Sure.
fine. It's up to you.
Yeah, I'll participate. And if you want to sit down, we'll go through
Well-
it all. And I'll turn that off for now.
Well, you can't tell me yes or no, it's how I talk to you.
Oh, okay. Usually I don't have a problem with that. Dr. Fazio, can I tell you I wanted to videotape my visit with you today?
Please,
Is that
go
okay?
ahead, sure.
Okay.
Is this gonna make it?
Yeah, we should be fine.
Okay.
But everything's been going wonderful, that's for sure.
How's your energy and strength now?
Great. What I've told people is that I'm not 100%, but I'm 100% better than I was before the surgery.
That's good.
Everything you told me was right on the head.
Well, first of all, your manometric studies, which are done in May, were excellent. So
Good.
that augurs very favourably for the outcome of surgery. Down from what your pre-operative values were, but that almost always happens, but in the course of time, usually about 3 to 6 months, they will come back up to normal again. The other bit of good news is that the x-rays look picture perfect. In fact, they'd be a sort of a postcard for that sort of surgery. Having any drainage from the rectum or anus?
No. other than when I go to the restroom, you know, some mucus will come out, but
Right.
not involuntarily.
Okay. You back at work, or
Yes,
what do you do again?
marketing manager at Manco. Or Henkel now.
Okay, well here's what to expect tomorrow.
Thursday.
Thursday, yeah. Under the anaesthetic I will do another check on the rectum with a digital rectal examination, and possibly scope the anastomosis at that time as well. We'll then place you in the supine position, prep your abdomen and make a circumferential incision around the junction of the bowel with the lining of the skin, deepen it in the abdominal cavity. We then retrieve the loop and bring it outside, trim the edges and close it with usually about 6 or 7 sutures.
Okay.
Drop it back inside and then do a muscle closure using an absorbable suture like Vicryl. The skin itself will be left partly open. We use a little purse string suture to narrow it.
Okay, this part of the video I'm going to show how the process works to empty out the ostomy bag. The first step of the process would be to grab a little bit of tissue paper, fold it in half, and set it down inside of the toilet to avoid any splashing while you're emptying the pouch out. It's a very simple process. For the purpose of videotaping this, you see I'm wearing some very tight-fitting athletic shorts, obviously for videotaping purposes. At home, under normal conditions, you would not be wearing something like this. The first step of the process is to grab the pouch in your hands, and the particular pouch that I am wearing has a Velcro bottom. You would make sure you have a good grasp of the bottom of the bag. You unlatch the 2 sides of the Velcro. You unroll it, make sure you hold it straight for a second, and then scoot yourself back on the toilet seat for a moment, and then you would dip the end of the pouch down into the bag with one hand, and then with the other hand walk any of the waste product out of the bag. You can move it around a little bit, and everything will empty down into the bag. And also what I do is to kind of press along with my hand and empty any air out as well to make sure and get the bag as flat as possible. The next part of the process is to clean the bag, and what I've done is, prior to sitting down, is to take some tissue paper again and have rolled it up to use it for cleaning the outside as well as the inside of the bag. So the first part is to kind of wipe off the outer edges that may be dirty, and then as you fold it, you can kind of work this tissue paper to the inside of the bag and start cleaning the inside, so that when you roll it back up, not much of the waste will exit out of there. And you can just kind of push it down in here, hold it, and walk this tissue paper around the inside lining to clean it as best possible. It's really a very simple process, doesn't take that long. And then one more, just for good measure, I make sure that it's as clean as possible. Obviously, that way nothing would have the possibility of leaking on clothing or anything like that. Once it's all cleaned out, again, you make sure to always hold the tip of the bag up so that nothing would leak back out of it. You hold it, fold it once, fold it twice, put your Velcro seals or Velcro tabs back down, and that's it. The bag is flat, it's empty, and you're ready to go back on about your day. Very simple process, and obviously it's done several times a day. Next, I'm going to show the process of changing the ostomy pouch. Change it on average every 2 to 3 days. And this is the process in which you go about changing it out. I want to videotape that here. For the purpose of the video, again, you'll see that I'm wearing some tight-fitting athletic shorts for obvious reasons. What I do is, on average, when I do get ready to change the bag, I try to do it first thing in the morning so that the stoma is not very active, and I will typically do it after I've taken a shower. So I'll shower, allow the bag to get wet, or the pouch to get wet. It's not a big issue. After showering, then come over to the sink area and change the pouch out, which is what we're going to do now. First thing to show you in the process of the camera swings around here, you can look at the counter. I've kind of set everything up as far as my supplies go. On the left side here, what I use are paper towels, the adhesive seal, which goes around the pouch to hold it onto the body, and then some scissors to cut it out, and we'll go through that in a moment. Also, I've got here a measuring device to make sure that I cut the hole on the pouch to the correct size. You've got some adhesive wipes. This one is an adhesive remover wipe, and this one provides a film barrier to make sure that the pouch stays on securely, and is one of the last steps. Also, there's a stoma adhesive powder, which again provides a protective barrier on the skin as to areas where it may have gotten red or raw, and you'll see that next. And also, I've kind of pre-cut or pre-torn some paper towels as part of the process. The reason for the roll of paper towels, you keep it here in preparing for changing this out to clear off any adhesive in wet areas. Take some paper towels, and what I do is tear it into 4 sections and kind of keep it in a stack here handy, so that as I'm changing the pouch out, I can use this as part of my supplies. So let's go ahead and get started. I keep a little bit of water running so that I can wet the paper towels. I'm going to take this towel here and just kind of tuck it into the front of my shorts, and you'll see why in a moment. Typically, I would just hold this towel in my hand. First step is going to be to remove the pouch and measure the size of the stoma so that I know the correct dimension to cut the new pouch to. There's a little tab here you can grab onto it, and then with the adhesive remover wipe, go along. And it makes it a little bit easier so that it's not tearing on your skin. And you can see here, you go along, you can see that wax seal starting to pull off. You just simply remove that, and then everything fold it up and throw it into the trash bag, which you'd want to keep handy here next to you while you're doing this. One important thing to mention, which I didn't mention in the beginning, is to make sure to empty the pouch prior to changing it out, so that there's not a whole lot of waste product in the bag. Just kind of drying up around this area first. You can see that there's still some adhesive around the area, and it's kind of red. Again, you take these paper towels, dry for now is how I do it. So you dab around here with paper towels. What I do too is I like to fold it, press it against the skin. You see it's leaking a little bit there. You want to catch that. And again, this is the reason for doing it first thing in the morning, is because that stoma is not very active. Haven't eaten in a long time. Otherwise, you're constantly trying to clean that thing as it's emptying out. Press it against the skin and for a second, dry, and it just kind of pulls some of that adhesive off. This is the process I've been using. Again, dry, pull some of that adhesive away from the skin. But you want to make sure and definitely get in there next to the stoma. Get as much of the adhesive off as you can. I think sometimes being dry is easier to do that. After you've gotten a fair amount of it off dry, what I do is take this paper towel again, fold it up, get it a little bit wet at the sink, use your liquid soap on the paper towel and start going around the area to remove the remaining adhesive. to obviously clean off the skin prior to putting the next ostomy bag on. Again, it gets a little active, you have to catch it. But not that big of a deal. Which again is a good reason to maybe keep a towel handy, but a lot of these paper towels pre-cut. I'll wet this again to remove the soap and things that are leaking out of the stoma. Leaking a little bit there again. See again, still some adhesive there. We'll try and get that off. More fluid coming out. So we're just about done getting all this off of here. You don't have to worry about cleaning the actual stoma itself off too much. That's not going to hurt anything. What I do is kind of squeeze water off paper towel over the area. Just have to dry the area off. Okay, pause. After you're done getting most of the adhesive off and drying off the skin, you're going to measure it. You can see here below the stoma that it's very red and raw. That's probably because of previous times I've had the seal on here. Maybe it wasn't sized perfectly. And if you get any waste leaking onto the skin, it will cause that irritation or that redness very easily. So next, keep paper towels handy in case this thing decides to get active again. You take the measuring device and measure the size of your stoma. That's like right at 7/8 inch, a little tight. 1 inch is a little big, so we're going to go somewhere between 7/8 and 1 inch as far as the size. So on the back of the pouch is a ring with the different diameters spelled out on it. Very easy to follow. Okay, take your scissors. Make sure again keep your paper towel handy if this thing starts to get active, which it is right now on me. Tuck this in here to kind of catch anything that comes out. Take your scissors and you'll cut a ring around. So I'm going to go probably right around, a little bit over 3/4 of an inch. And follow it just right around the circle there that's pre-printed on the back of this pouch. The scissors make it very easy. They're kind of rounded. They're not straight like traditional scissors, but are rounded, so that makes it easier to cut in a circle. You put that into the trash, what you have here. One important thing to point out too is in the beginning of this process, make sure you fold the end of the bag up and close it. The last thing you want to do is put this on, leave the end of the bag open and have it leaking on you. Next you're going to remove the plastic liner and expose the adhesive ring around the back side of the pouch. This is a adhesive seal that holds this pouch very firmly onto the body, securely I should say. You're going to open this up a little bit to kind of fit the hole that you've cut out. Place it on the back of your seal. And you can widen this adhesive seal out with your finger. Make sure and press it down real good against the back of the pouch. Again, make it as wide as you need it to be to match the hole that you just cut on the back of the pouch. So I've got this on the back. I'm going to let it set for a while and get even more tacky so that when it gets onto my skin, it holds really well. And we'll leave that sit over here for a moment while we finish the rest of the process. The next step in the process is to use this is where we're going to use the powder to kind of give some relief on these red and raw areas. This forms almost like a new skin barrier. What I do is just take the paper towel, take off any excess powder, wipe it off this way, and then I usually just kind of press that powder into place, and it will stick where it needs to stick in those really raw areas. Don't be afraid to put some more on there if you need to. If you do miss an area, just kind of shoot it there onto the skin. I kind of press it in place here with the paper towel. Then you take your barrier film wipe, open that up, and put this right on top of the powder to kind of seal it in. If you put your adhesive in your pouch directly on that powder, it's not going to stick very good. This barrier film seals that powder in. Then you want to wipe it around the skin area too, which gives you a nice good surface for all that adhesive to stick to. I'm going to kind of make sure that this is dried out. You can just kind of blow on it and wave with your hand. Make sure it's nice and dry. Well, I've got this off. You can see here too, my scar from the incision, but also there's a little bit of a section of skin that is kind of swollen still. That's fatty tissue and tissue underneath that is still swollen from the surgery. And there's a little bit of you can see where my drain had come out, and that's healed up very nicely. But this should absorb as I continue to put more weight on, and this should fill in and flatten out like the other side of my abdomen. Next and last, really, take the pouch. Don't put it straight on. What I do is I kind of tilt a little bit of an angle so that this plastic flap isn't hanging straight down into the genital area. Just kind of turn it on a little bit of an angle, which will then make it more comfortable for you to wear on a daily basis. I then kind of look in the mirror too, eyeball from the back, and on the mirror I can see through. This is a clear pouch to make sure that I'm getting it on straight. Once I've got it in position, I kind of push around that ring. Once I got it in, make sure the rest of the adhesive is flat and sticking firmly to the skin. Push against the abdomen to make sure there's a good seal. Again, all the way around that hole where the stoma comes through. You want to minimize any leakage that you might have. And then just hold your hands over top of that pouch for maybe a minute, 2 minutes to kind of keep that adhesive warm. It adds a little extra pressure as well to make sure that that adhesive ring as well as the adhesive on the back of the pouch is securely against the skin of the abdomen wall. And then you're ready to go for the day. One of the things too that I'll point out is the way that I wear my pouch is like you see it here, is I wear it on the outside of the underwear. These are just adhesive or tight pants, tight shorts I have on now, but I do wear it on the outside versus tucked in. That way it's not rubbing against my skin and poking me or anything like that. So I'll wear it on the outside of the underwear and then pull my pants, whatever it is I'm wearing, up over top of that, and make sure that the waistband of the belt is above the level of the stoma so that you're not cutting it off, causing any damage, or not allowing it to perform as it should. So that is the process, how to go about changing the stoma. Again, keep a lot of paper towels handy so that if that stoma does get active on you, you have something to clean up with very quickly. And the other thing that I recommend, and the way that I do it, is to change it first thing in the morning so as to minimize the amount of activity. If you try to change this after you've eaten, your body is starting to process that food, and that stoma will be very active, and it'll make it very, very difficult for you to change that very quickly.
course.
See you later.
Bye.
Bye. Okay. And away we go. This is a pretty good hike for you getting across over there, huh?
Well, we just got one bridge today. But you're going down to the H induction. Then you'll be coming up the hill. They let me video camera all this?
Mm-hmm. Yeah, it was with Dr. Fazio on Monday,
Uh-huh.
taping my meeting with him. I was asking about this, and he says, yeah, he doesn't have a problem with it. Obviously, getting into the room is a different situation, different story.
Yeah. Little bump here.
But I've been because I had surgery in April. This is the second part of it.
Uh-huh. Oh, okay.
So I've been videotaping the whole entire process and what all going through.
Okay.
See, you're lucky I'm so light getting up that hill. You don't get too good of a workout pushing me up that hill.
Shame.
You get you a good 300-pounder, get you a workout.
That's a code too.
Yeah. I'm sure you have them too. Was that a 2-man push?
Yeah. 3-man.
3-man push?
Watch your backside.
Okay, so I'm a little bit better, but it's.
Hey, Don, there's someone looking.
Right before I take you out. Not yet. As soon as I can, I'll let you know.
No, this is nowhere near as far as last time. And that's the book. Bonnie would like that chart. I got a long enough wait, so I'll flip through here and see what's all on the chart. Been reading this thing. See, everything here is marked along the top for labs and everything else. Everything's on there. And these are the notes from the visit on Monday. I just flip through the whole thing. There's my rap sheet. Clinical notes. This goes back to August 21st. That's for the polycystic kidneys. These are the notes from the first surgery. Everything they did.
All right, the room knows you're here, all right? Someone should be in to speak for both of you shortly, okay? In the meantime, like I said, two of you need anything. Just feel free to let the others know. Okay? Siobhan, I hope everything goes well for you this morning. Okay?
And there's the transfusion documentation. And apparently, I am O positive. O positive is my blood type. I got 4 units of blood first time around. There's the first 2 on April 2nd, and there's the second 2 on April 4th. April 4th.
Was you with them? Nope. I'll just meet you. All right. Okay. Nope. Good luck to you.
Thank you. To the next waiting area, huh?
Yeah.
So did I get lost in the system or just backed up?
Oh, yeah?
Yeah, because I was supposed to be in the OR at 7:30.
Real?
Uh-huh. Was sitting around waiting.
You make sure you question that, though.
They said they had an emergency case or something came in.
Yeah, okay, that's understandable. Yeah.
So I
They
just
do have emergencies like
been reading the paper and hanging out.
that. And what's that you got?
I've been taping the whole experience because it's been a 2-part surgery for me.
Oh, okay. So you take the actual surgery? Or
No, I
Just you going
can't
to
do
and from?
that yet
Oh, okay.
because I did everything beforehand and afterwards.
Oh, okay.
But this is one part that I hadn't thought about doing before. Yep, I remember this hallway for induction. At least these rooms up here have TVs in them from what I remember.
Did you get an induction room?
Yep.
Eight? Okay.
Next stop, huh?
Yep.
Hello, how are you?
ya?
Good.
My name's Tracy. I'm a registered nurse. I work down in the OR.
Okay.
And you are going to see Dr. Fazio.
Yeah.
Did you speak with Dr. Fazio about having
Yep.
Now what is this for? Just home movies?
Well, yeah, it is, but I'm gonna try to edit all my footage down to maybe like a half-an-hour video, so that I run the support group for the Crohn's Colitis Foundation. I'll try to put together maybe like a half-an-hour video, so that somebody who goes through this, like I am, if they have questions, they can watch my experience and know what the incision would look like, and all the steps of it. And some people maybe have never even seen the inside of an operating room. I want to film going into it, but obviously I cannot film the actual procedure. So if somebody can, if it can help somebody else through the process, then great. Because I had a ton of questions for the, for the first procedure.
Well, do you?
Yeah, just however you guys have to do it. Doesn't matter to me.
I don't have to do it. I do it
Doesn't
for
matter to me.
patient comfort sometimes.
Yeah. So right now they're just getting the operating room ready, and I'm sitting out here in the hallway, just waiting to go in. Obviously not a very busy area, but I should be in there in the next couple of minutes. It's about 20 after 11. I was scheduled for 7:30, but got pushed back. To watch it and answer some of the questions that I had going into this.
Right.
I run a support group for Crohn's Colitis Foundation, and hopefully we can use this to help people get more comfortable with the procedure. So we'll see. How you doing?
Hi there.
So this is the room we'll be getting all patched up in, huh?
This is it. This is your home for the next hour or so. Uh-oh, who's got a video camera?
Smile. So make sure everybody's happy, especially Marlene.
She's smiling. I got 4 right now.
I think I'm holding it steady. Does it look like it's going steady?
Okay, put that on your machine. You're gonna need that.
And what are you taping?
He might make a documentary.
Ah.
Putting together all my footage,
Hang that up on that pole over there.
and then hopefully edit it down to something.
He's our neighbor.
Shorter.
Well, he's closer to you than
You're
me.
in Strongsville, I hear.
Yeah. Where you at?
Back by Boston Road.
Okay, that's where they wanted to widen it or put that other.
Yeah,
Did
so
they ever
looking-
make a decision about that? They keep
I have
blowing that
no
off.
idea. I don't know where that's all at. But I'm behind
Where?
behind High Point. You know that development, High Point?
Oh,
is
yeah,
right.
yeah, that's very nice.
back in
High
that area.
Point ended up, going farther. Remember Vera?
Let me move over.
Is that where Vera?
Yeah.
Yeah, come on over.
Come on over.
We worked with. She's up. Did I tell you I ran into her? She told me to tell you hi.
Oh yeah. Oops, sorry.
That's all right. She kind of beat me up. Enough from Vic. No, I'm just kidding. I raise yours in there, babe. That's good.
My wife works over at Euclid Hospital,
Oh, really?
so she's got a little bit of a drive when she goes over there,
Strongsville would be nice.
wouldn't it? I know. Right there by the mall.
Yeah, but the only problem is you spend so much time at the mall, you waste your whole day.
That's true.
So there are
It's
some
dangerous
downfalls.
to be there. That close to one. Okay, cross your legs, son.
My kids keep her there enough as it is.
Oh, at the mall?
Yeah.
This is your seatbelt.
Okay.
That's okay.
Need stocking stuff? I do. So again, I'll go. You got this chair and a table? Oh, you're good. All right, well, watch yourself. For you, Mrs. Amber. Thank you.
What's the music selection going to be today?
Hello.
Hi, how are you?
Hey,
You don't listen to music much in here? Come on.
Today
Really?
we sort of had an emergency case before. You probably found out about that.
Yeah, believe me, I know.
So we weren't really having too much fun this morning, to be honest.
Okay, I'm gonna put this.
Okay.
Okay, a few more EKG pads. How are you doing with your anxiety?
Good. No problems.
No nervous? No, not nervous at all?
This is a walk in the park compared to the first one.
I'm glad you feel that way. Let me,
You're supposed to reassure me and tell me it is a walk in the park compared to the first one.
Did you see him yesterday?
Yes, it is. Okay.
Did you see him yesterday?
Yeah, I saw him.
Monday.
No, I saw him Monday.
Did he get cracked in the office? I don't think so. Did they look up your butt in the office?
No, they did not. They did that a month ago.
I don't want to look together.
Put this. Mine's right here. Stick a finger.
All right, Nancy, what else?
Okay, your
Gonna go ahead
stockings
and
to
measure-
prevent your blood clots.
Okay.
Do you remember these?
Yep.
Alrighty.
And you probably remember the blood pressure cuff. It's gonna squeeze your arm a
Yes.
little bit. It's probably the worst the first time, and then it's gonna be easier and easier
Okay.
on your arm there.
Marlene, did you drag us in the room?
And maybe if you hold your arm, maybe you can hold it with the other way,
Okay.
because you need to hold this straight. Yeah, sort of.
Okay.
See that? Otherwise,
Hey,
the
there
cup
I
is
am.
not gonna like it.
You got it.
Very good.
So I'd be running, but I flushed it, so it seems like it's working fine.
It's not, but
It was not running, but I flushed it and it's now it's out.
you guys wanna push Dr. Lewis?
Or she went to the next room and she said she's gonna be right back.
Okay. Okay, we're gonna go ahead and get started with the mask and
Okay.
do anxiolytic, try to fill your lungs up with oxygen, the so-called pre-oxygenation process.
Who's actually going to be doing the procedure?
It's Dr. Fazio.
It isn't. I figured
Yeah.
probably a fellow or resident would be doing it.
There's only just a resident helping him today, but
Okay.
he's gonna be the one that, let me get this around like
Okay.
this is probably better. All right.
All right.
I'll tell you
There we go.
what,
Now
you
we're
shouldn't
recording.
have everything down there that you know, the little red
that's going.
That means it's recording, so that's good.
Yeah, bedtime.
So this one we go out right here?
You are put to sleep. I'm trying to get your face in the middle of this. You are put to sleep when the anesthesia team thinks you're ready to go to sleep, and they're assessing the oxygen in your blood and your blood pressure and your heart rate, and making sure that all that is good. That mask you're getting is just oxygen. There's no gas in there. The gas doesn't go in until after you're asleep. The medication goes in through the IV that puts you to sleep.
Marlene, you making the movies?
I'm making movies, yeah.
Co-producer.
Oh, I see where it says record on here.
I think she deserves at least co-director.
Co-director, there you
Oh,
go.
I don't know about that. Now, when you came down here, did you like take pictures of the ceiling?
I tried to.
Yeah?
Trying to get the lay of the land. You know it more than I do, so I'm just trying to.
I saw a movie similar to this sort of thing that explains a patient, what they're going through. And it was done, I think, by a medical professional. And they just took pictures coming down to the operating room, laying in the cart, and just what you saw. You see people walking around in the hallways.
Feel free to pan around the room, because you know it.
Pan around the room, okay. Does anybody object to that in the room?
I guess it's okay. I'm not the most photogenic person this morning, but.
Oh.
If that camera adds 10 pounds, we gotta adjust.
See?
Oh, then I really don't want to get John.
How about I'll just concentrate on machinery. This is the anesthesia machine. We'll get a picture of your blood pressure and your pulse.
Everybody, did you feel what you needed to? For all our future patients out there?
Yeah.
All right.
Shows your blood pressure and your pulse. You want to be on film?
Perfect.
Perfect. Surgical instrument table.
Pretty good. He's totally stable. Actually started waking up, so there's one time the pressure is totally stable.
Is this the first time you've had this request, Marlene?
Yes, this is the first time we've had this request.
Nice deep breath in and out there.
We're going to take very good care of you.
Feeling really sleepy here today.
I'm gonna, again, when you work, it's some lidocaine, and that's the numbing medicine. This is a small IV. The good thing about this medicine is it has a low incidence of nausea and vomiting. And it doesn't seem to leave you as groggy post-operatively as things like Pentothal does. So, there's some very good things with it, but it isn't comfortable when we inject it. I can tell you that. So,
Will it make
it's
me,
like almost every drug. You get the good and the bad,
will it make me taller and give me more muscle?
I don't know. It could be. We could report it if it does.
That'd be interesting.
We're always looking for good cases. All right, here it comes.
We always appreciate when
Good night pretty soon, I guess?
Yeah, you sure will. Okay.
I'll say good night pretty soon.
Good night.
Count down 5 from 10.
Okay. Deep breath for me. In and out. Excellent. Excellent. Very good.
Mr. Ritson's been waiting for 3.5 hours because of an emergency, and he still has a sense of humor. We appreciate that.
How you doing? Is your arm okay? I want you to tip up your chin for me. Angela? Okay, and tip their head back.